This presentation is going to focus on the nutritional requirements for patients with diabetes mellitus. And if you're following with the PDF slides that were available this week, I'm going to be going over the objective slide and then starting with slide 29, moving right into nutrition. So at the end of this presentation, if you have already worked through the definition of diabetes, we will go right into the nutritional goals, and you should be able to identify the role of vitamin D in the onset of diabetes, compare and contrast type 1 and type 2 diabetes. You should be able to explain the main goal of diabetes treatment, how it can be achieved, and start thinking about the composition and the process of diabetic management and the team that is required. I'm talking about the interdisciplinary team that is required to help patients meet their nutrition therapy goals. And lastly, you'll be able to identify groups for whom special care and individualized goals are needed. So we're jumping right into slide 29. The goals of nutritional therapy for patients with diabetes is to first attain and then maintain the optimal metabolic outcomes for not only their blood glucose, but their lipids, their lipoprotein profiles, and blood pressure. We also want to prevent and treat any further complications that may arise from the inability to attain and maintain optimal metabolic outcomes. And we want to help our patients improve their health through healthy food choices along with physical activity. And you can see from this figure from your textbook the plate method for diabetes meal management. And what it's suggesting is on a 9-inch dinner plate, you want to fill half of that plate with non-starchy vegetables. So salads, greens, cauliflower, cabbage, carrots, other than starchy vegetables like potatoes. Then you want to fill 1/4 with a lean protein like turkey or chicken, perhaps beans, tofu, or eggs. And then the other 1/4 with grain or starchy foods like your potatoes, rice, or pasta. However, it is also recommended that you can skip the starch altogether and then double up on a non-starchy veggie. And this is coming from the CDC's plate method. And you can find that by going to cdc.gov/diabetes/managing eat well meal plan method. Overall, our goal is to address the individual nutritional need because everybody will have just a little bit different personal, cultural preferences. They'll have different lifestyles and their motivation or willingness to change. And that can be on a spectrum that can move from being very motivated to not motivated at all and everything in the middle. And even then, that can change over periods of time. Medical team members are responsible for providing nutritional therapy. The main person is the registered dietitian or perhaps the diabetic nurse educator. A registered dietitian is someone that's going to be knowledgeable and skilled in the nutritional therapy for diabetes, and they will maybe further train the other healthcare providers, the family members, including, of course, the patient. It's essential that the other healthcare team members are knowledgeable as well as the family so that we can support our patients and that we understand the implications of the dietary choices that diabetics need to be aware of. This also lends us to be supportive to the patient's family and encouraging them to make important lifestyle changes. But first, we have to understand. Now, it is an integral component, this nutritional therapy, but it's not the only component of diabetes management. And so what our goal is for this course is to help you understand the nutritional goals so that you can use them alongside the medical goals that you're learning in your Med-Surg course. This involves conducting a nutrition assessment to evaluate the patient's food intake, metabolic status, lifestyle, and of course, their willingness or motivation to change. Help them goal set, teach them, provide nutrition education. They may be needing individualized counseling, monitoring, and of course, evaluation and re-evaluation. We also need to maintain consistency within this eating pattern that we're asking our patients to adopt. And rather than following just some arbitrary eating style, which can help result in a lower A1C over time, we also have to think about the other issues that may come up. Again, their preferences. Maybe what we are suggesting they replace their favorite foods with. Think of sweeteners. Now, although fructose creates a small rise in plasma glucose than sucrose does, and other carbohydrates, large amounts of fructose provide no advantage as a sweetener. There are other what we call nutritive sweeteners, such as corn sweeteners, fruit juice, or juice concentrates, honey, dextrose, maltose, molasses, that affect glycemic response and caloric content much like sucrose does. Think of sugar alcohols, anything ending in OL, sorbitol, mannitol, xylitol. These result in lower glycemic responses than the other carbohydrates do. But if you ingest large amounts, they can have a laxative effect, which would not be the preference of your patients. Nutritional therapy is an essential element helping our patients to achieve glycemic control and eventually, and more importantly, diabetes self-management education, sometimes referred to as DSME. And this is an individualized nutrition therapy that's required to achieve these treatment goals. So what's the basis for this therapy or this DSME? We have to allow our patients the opportunity to be the recipient of a comprehensive nutrition assessment, a self-care treatment plan, and understand the client's health status. We also need to assess each individual patient's learning ability or health literacy, their readiness to change, and what their current lifestyle looks like. This is the key to tailor the meal planning approach to our individual patients. And so there is no ideal diabetic patient or no ideal diabetic diet. In the past, physicians ordered a certain calorie level, but now we know the American Diabetes Association doesn't endorse this type of nutrition plan anymore. They no longer endorse any meal plan or specific percentages of carbohydrates, protein, and fat, or those macros. And they don't endorse any exchange lists. The diet orders that were once no concentrated sweets or no sugar added, low sugar, these aren't suitable because they don't reflect what we currently understand regarding diabetes nutrition requirements. These old rigid meal plans really propagate a false notion that if you can just stick to these certain things, restricting sucrose sweetened foods, your blood glucose is going to be controlled. But that is not the case. So we're going to look into these sweeteners in a little bit more depth. Non-nutritive sweeteners that were and are approved by the U.S. Food and Drug Administration, or the FDA, So think of aspartame, acesulfame, K, saccharin. They are considered safe for consumption with patients that have diabetes, according to the FDA. And each product has undergone rigorous testing and scrutiny before the FDA approved them for consumption. And they have been found safe when consumed by the public, including pregnant women and diabetic patients. Now we're going to move on and talk about our role in nursing. The role of the nurse is to primarily advise patients with diabetes regarding the various types of decisions that they need to make on a day-to-day. And this is going to vary according to the setting that you are seeing the patient and the age of your patient, as well as whether they have a type 1 or a type 2 diabetes. However, there is a general approach, and this is to first assess the patient's knowledge of, their understanding of, and their adherence to the diet that is being recommended. And when possible, if you can actually observe the meals that they are eating and watching them as they're making their food choices, as well as making sure that they can return demonstration by monitoring their glucose levels. This really gives us important clues to the level of our patient's compliance. Now, when adherence is not so good, the nurse can offer information and support and encouragement primarily. There will be knowledge deficits that we can help bridge that gap. We can also provide motivational interviewing to assess that lack of motivation and come up with goals for nutritional therapy that our patients can actually start to achieve. For example, if you have an adolescent patient with perhaps type 1 diabetes, they may not really understand or accept the gravity of this long-term, lifelong disease process with complications. And they don't really understand that it could be related to their diet primarily, and they may not be as motivated to eat what we're instructing them to eat because they have their peers around them that make it more difficult for them to subscribe to such a stringent diet. Or you might have an older patient with diabetes, perhaps type 2, and now they have to change a lifelong eating habit and lifestyle changes. And this may be too overwhelming, and they may not want to change. They may just want to take medication for their hyperglycemia and overall their diabetes. So by providing a non-judgmental, trusting relationship between you as a nurse and your patient, you can start thinking about what are your patient's main concerns, what are their motivations, and what would they like to discuss. And you can help them and influence the patient to be more concerned about their long-term welfare after you've established a foundation of truth. Now, there is a teaching toolbox, and you can find this also in your textbook, some information about this. But teaching toolboxes regarding diabetes care management and nutrition, they are provided by community agencies and associations. Now, if regular foods can not be tolerated in times of illness, then we still need to supplement this somehow to provide energy and also to prevent dehydration. And so you need to think about how we're replacing these carbs. Are we going to replace them by adding liquid, semi-liquid, or soft foods? And we want to provide carbs in either 15 grams every 1 to 2 hours or 50 grams every 3 to 4 hours. Of course, if our blood glucose is higher, then we need to provide less. And so we have to make sure that we're monitoring the actual blood glucose frequently. We also have to promote the amount of fluids that they're taking in, at least 8 to 12 ounces of liquid every hour, and preferably that is water. And we want to help them to maintain a minimal amount of salty foods, and we have to give them a little bit of salt because they may, because of their illness, be suffering from vomiting and diarrhea, leading to even more dehydration. And of course, where fluid goes, or water specifically, salt or sodium follows. Approximately 20 to 30% of patients with diabetes will experience some type of delayed gastric emptying, and this is called gastroparesis. And when we have delayed gastric emptying, this can manifest as heartburn and feel much like GERD. Your patients may have abdominal pain, nausea, vomiting, and even feel full very early and easily. This is called early satiety, and it may even lead to weight loss. Now, gastroparesis occurs from vagal autonomic neuropathy, and it occurs more often in our type 1 diabetics, but it can also happen with our type 2 diabetic patients. Now, dietary treatment for our patients with gastroparesis involves careful monitoring of their overall intake. And we're trying again to replace their carbohydrates with foods that are coming from a more liquid or semi-liquid or soft consistency, easier for the GI system to tolerate. During these times, we're promoting smaller meals, about 5 or 6. This is going to be tolerated more easily than taking in 3 larger meals. And this is just nursing consideration of generally any patient that is undergoing gastroparesis, not necessarily just our diabetic patients. And we want to promote a low-fat diet. This will also be useful to prevent this delay in gastric emptying. If your patient is suffering from the side effects of gastroparesis, like constipation or diarrhea, we may need to increase fiber. If they have dehydration due to the loss of fluid, we may need to increase their fluids, moisten their food, and add broth. Encourage liquids, water. One medical intervention that is typically used for delayed gastric emptying is Reglan. And this increases the gastric contractions and relaxes the pyloric sphincter. Using Reglan can help our patients. However, they may experience dry mouth and nausea as a side effect of Reglan, things that they may already have. Now, if the patient complains of dry mouth, then you're thinking about foods that can help increase their amount of saliva and bring back the fluid. So hot foods can be moistened with broth like I talked about, but ultimately you are encouraging fluids. Now, if they're in the hospital and they're not able to take in these fluids, we may have to think about fluid resuscitation. And our insulin, of course, has to be matched with our meals to regulate the delayed absorption, which also comes with glucose changes. If constipation and diarrhea occurs, not only can we promote fiber, but the formation of an indigestible solid mass, which we call a bezoar. This can occur after eating things like oranges, coconuts, green beans, apples, figs, potato skins. You see the list here. If this happens, then you might have to temporarily feed your patient with an NJ tube, or they might need a temporary duodenostomie tube, which could be indicated to help them with this issue. In type 1 diabetes, eating disorders are somewhat common. And once insulin therapy is initiated, which is not for type 1 diabetics, it's not negotiable, right? Your body isn't making insulin. So you are going to replace that insulin. Oftentimes, when you give patients insulin, they start to gain weight. And so these patients may be more prone to having disordered eating and body image problems. And we call this diabulimia. And what can occur and what you may need to assess for is that they may be omitting their insulin or not taking their insulin to help control their weight, which is dangerous because their body does not make any insulin at all. So what are the warning signs and symptoms of diabulimia? I want you to go into your textbook and look at box 15.7 for more information there. Now, insulin restriction to keep weight under control needs to be a red flag. And if this happens, in addition to nutritional therapy, you may need to have the patient's overall mental health evaluated. So there's a strong connection between the two. And here it is, the warning signs and symptoms of diabulimia. Now, not only are you looking for the physical symptoms, but consider the emotional and behavioral symptoms as well. And I'll give you a couple more seconds to look at this list, and you can mark it in your textbook to go back and review. Metabolic syndrome is something that we need to talk about because it often incorporates or leads to diabetes. Metabolic syndrome is when we have a disproportionate amount of abdominal fat depositing around the midsection. It leads to excessive secretion of cytokines. And when we have a chronic low-grade state of inflammation in our adipose tissue, it further contributes to type 2 diabetes. Not only are we worried about type 2 diabetes, but we're also worried about cardiovascular disease, all in the realm of metabolic syndrome. If you have 3 out of the 5 of these following symptoms, you are considered to have METS or metabolic syndrome. So, a waist circumference over 102 centimeters if you're a man, or 88 centimeters if you're a woman, triglycerides over 150, HDLs, which are your good cholesterols that are less than 40 if you're a man and less than 50 if you're a woman, blood pressure, systolic over 130, diastolic over 85, a fasting glucose over 100, or again, if you have 3 of the 5, you are in metabolic syndrome. Now, we also have patients with diabetes, and a successful pregnancy for someone with diabetes really requires a lot of commitment and a lot of planning, lots of interdisciplinary care. And because we know that many fetal malformations occur during the first trimester of pregnancy, we need to achieve and maintain excellent glycemic control even before conception, and especially during early pregnancy. These are going to be both essential. Now, women that have pre-existing diabetes and then become pregnant are at a high risk, and they are vulnerable to fetal complications and compromised maternal health risks. Gestational diabetes, on the other hand, this develops at around 24 weeks of pregnancy, and these women do not have a history of diabetes. Gestational diabetes occurs more often in Native American, Black American, Hispanic, and Latina American women. Women who have GDM, or gestational diabetes mellitus, also are often obese. However, during pregnancy, weight reduction should not be attempted. Too risky for the baby. Something that you would manage after the delivery. Now, gestational diabetes, as opposed to a diabetic woman that gets pregnant, with gestational diabetes, it will resolve after you have the baby, but it does put you at a higher risk for diabetes type 2 in the future. There are also studies that will suggest that your infant is at risk for hyperglycemia as well. Now, increased insulin in your body in someone that has gestational diabetes can also cause macrosomia of the fetus, or a really large baby. So patients with gestational diabetes often have infants that are larger than 9 pounds if not managed well. For these patients, we need to individualize their nutrition therapy, recognizing that they are at a high-risk category, and it is contingent on maternal weight and height. Providing adequate calories and nutrients should be the focus of the pregnancy and needs to be consistent with the established maternal blood glucose goals. You can find this on the table in your textbook on 15.6, but overall it's going to be established by your obstetrician and perhaps perinatal specialist. Blood glucose monitoring is going to provide the information that we need to see how do certain foods impact the patient, and we use their blood glucose levels to tell us that information. Now, at the start, at a minimal, we are asking our patients to take their sugars after they eat 4 times a day. So first we're taking a fasting blood sugar, and then 1 to 2 hours after every meal. And it's not uncommon for these pregnant patients to test blood glucose levels even 8 times a day if they had diabetes prior to their pregnancy. Now, if they're fasting, really we want those sugars to be less than 95. After they eat about an hour, it should be no higher than 140, and after 2 hours postprandial or after they eat, it shouldn't be higher than 120. In terms of weight gain, there's no unique weight gain recommendations for women with diabetes. Obviously, we don't want to be excessive, but we need to also pay attention to the growth of the infant. It needs to be steady and progressive. Thin women should gain more weight, obviously, than overweight women at baseline, and even obese women. Just to give you some perspective, if you are already starting in the obese BMI category, your weight gain should be no more than 15 pounds during pregnancy. No calorie adjustments are needed during the first trimester. However, during the second and third trimester, we need to increase their kilocalorie intake by 100 to 300 kilocalories a day, which is recommended. We also need to promote high quality protein by 10 grams every day, and it needs to be in the form of lean proteins, right? High quality proteins. We also need to think about allowing your patient to have 2 extra glasses of low fat or skim milk and perhaps 1 to 2 ounces of meat or some type of meat substitute. With pregnancy, we need at least 400 micrograms a day of folic acid. This is to help prevent neural tube defects, very important, and now integrated into overall prenatal care vitamins. Alcohol should not be consumed in any amount. In terms of energy restriction, we have to be very cautious. A minimum of 1,700 to 1,800 kilocalories a day of carefully selected foods need to be processed through our body to prevent ketosis, and taking anything less than this amount is not advisable. Please refer to your table in 15.6 to look at the nutrition recommendations for diabetes during pregnancy. Please take a moment to check out this table, look at the differences between during pregnancy, postpartum, and even times of breastfeeding. This will help you in your future case studies. What about pregnancy and overt diabetes? Really, the optimal period of care for women with diabetes is before conception, like we said, right? We need to start thinking about this before they even get pregnant. And ideally, this preconception counseling should happen during puberty and then throughout their childbearing years. And so this really is a group effort, not only by their obstetrician, but their primary care provider and any nursing staff that has an opportunity to work with the patient. Your A1C or glycosylated hemoglobin levels should be normal or close to normal before conception is even attempted. The insulin requirements during the 2nd and 3rd trimesters of pregnancy will increase because of higher blood glucose levels caused by increased production of pregnancy-associated hormones that insulin is an antagonist to. Successful preconception care programs have used the following goals. Before meals, we want to have a glucose that is between 70 to 100. 2 hours past, 140 milligrams per deciliter. Now, pregnancy is going to require greater attention to nutrition on a day-to-day basis. Anyways, we know this. And so early guidance during the early stages of pregnancy need to also address any signs of nausea or morning sickness and food cravings. The meal plan for your patient with diabetes should be individualized. It should think about their preferences and meet the changing nutritional needs as well as insulin requirements. Usually 3 meals and 3 snacks are recommended for our diabetic pregnant patients, and there will be a use of frequent home glucose monitoring, and this is to help maintain normal fasting as well as postprandial or after meal glucose levels. Now, good glucose control is usually accomplished by individualizing the intake of the food and graphing out your patient's weight. And often insulin can be prescribed in addition to this individualized meal therapy or plan. This is going to reduce the risk of fetal macrosomia, neonatal hyperglycemia, and also perinatal mortality. Treatment options can also include oral anti-diabetic pharmacologic treatments. Many times, our patients will be on a medication called glyburide or will opt for insulin therapy during pregnancy. Now, glucose levels usually revert back to normal after delivery if they have gestational diabetes. But again, there is an increased risk for later development of type 2 diabetes. The prevalence of type 2 diabetes among races are something to think about too. Asian Americans should be screened for type 2 diabetes even at a lower body mass index than any other racial group, and this is coming out of CHOBI 2017, which is a research study that has looked at the different ethnic makeups to see who has more risk. Now, if we compared with white Americans using the standard BMI criteria to screen for risk, you're going to see that a large proportion of racial and ethnic minority groups are being overlooked. And so CHOBI is one of those research articles that have illuminated more information and to help healthcare workers to be more culturally competent. Overall, the incidence and prevalence of type 2 diabetes in children is also a problem, especially in our ethnic minority populations. Within the last 20 years, it's increased 30-fold. So that's an astounding number, and this turns it into an epidemic. Now, what is promoting this epidemic of type 2 diabetes? Overall, it's childhood obesity, and that burden of diabetes and its accompanying complications affect many patients and many patients' family, and it puts an enormous strain on healthcare resources. But also think about the young patients that are now taking medications and are maybe even going to need medications for the rest of their lives if we can't help them with these lifestyle changes. Also to note that girls are more susceptible than boys to type 2 diabetes, pediatric type 2 diabetes. Generally, children and adolescents with type 2 have poor glycemic control, and as in adults, ideal treatment is to normalize their glucose and their A1C. We also need to think about controlling hypertension and also hyperlipidemia, and that makeup or triad of metabolic syndrome. The initial treatment for these patients really depends on the clinical symptoms that you see. We're trying to decrease the risk of diabetes ketoacidosis or diabetic ketoacidosis, DKA, as well as hyperosmolar HHNS, which are both associated with a high level of morbidity and mortality in our pediatric population. And in addition to nutrition therapy and exercise being first-line treatments, obviously, we also many times will see that children that are diagnosed with type 2 diabetes really require drug therapy. And insulin right now is the only FDA-approved drug for the treatment of diabetes in children, but oral agents are often used for pediatric diabetes as well. Just like our adults, we need comprehensive self-management educations. Think about the clever tools that we can use to teach children, different type of population, and how we can promote better eating habits and lifestyle changes. And you'll understand this even more so when you go through your PEDS course. And lastly, our patients on the other spectrum of life, our elderly patients, are going to be more at risk for the development of both macrovascular and microvascular complications. Overall, they're at a higher risk for cardiovascular disease as well. They generally will have more issues complicating their disease management, like frailty, depression, urinary incontinence, dementia, impaired vision, altered kidney function, and the tendency for recurrent hypoglycemia. So, according to the Diabetes Council, there are key factors that we need to consider with these older patients. We need to think about their ability to manage their diabetes independently. Are they capable of their activities of daily living, or their ADLs? Do they have a cognitive impairment? And can we avoid low blood sugar or hypoglycemic moments? How can we help to maintain a stable A1C, daily blood sugar goals, including fasting and postprandial, and how can we help them adjust their insulin or oral glycemic medications if this is part of their overall plan? A1C and blood sugar goals can be more relaxed, but we need to take the correct steps to avoid acute problems like DKA or HHNS, and avoid any complications that will further lead to their functional capacity or a decreased functional capacity.